that's a little how osteopathic medicine is similar to the MDs because they train together. Let me tell you a little bit about my school, the School of M. I'm at the Lake Erie College of Osteopathic Medicine in Bradenton, Florida. We are the largest medical school in the United States. Between our 3 campuses, we accept a little over 600 medical students per year. We have 3 campuses. Main campus is in Erie, Pennsylvania. Second campus is in Bradenton, Florida, where I'm at. And the 3rd campus is up in Seton Hill University, out towards Pittsburgh. The 2 campuses up in Pennsylvania, they have 4 seasons. I'm in Florida, we have 2 seasons, hot and nights. The weather down there is a lot better than up north. This is kind of cold for us in the wintertime. It's kind of the program that we have at these various campuses is quite unique. In the Erie campuses, they have 3 curriculum pathways. The first pathway is a lecture discussion. That's where they have PowerPoints and you're in class 8 to 5, Monday through Friday. The second pathway is independent study. And that's when you work one-on-one with the doc for the first 2 years. Whatever the doc knows, you're going to know. Third pathway is problem-based learning. Problem-based learning, anybody know anything about problem-based learning? What problem-based learning does is teaches the best and the hell with the rest. Teaches you what you really, really need to know as a doc. And so the curriculum that we have down in Bradenton is just one curriculum, and that's a problem-based learning curriculum. The curriculum down there, let me show you how problem-based learning works. I'm sure you already know how independent study works when you're with a doctor. And you lecture discussion, PowerPoints predominantly. Problem-based learning is most unique. You learn by means of cases, actual cases. It starts the very, very first day of med school. Not the 3rd year like in a lot of med school. This is the very first day of med school. Now the whole thing is based upon teamwork. And we have 160 students in our class down there. And we have 20 groups, and we have 8 students per group. So let's make believe that you 8 students are in my group, and I'll be the facilitator. Now the group makes all the decisions. I, as the facilitator of the group, I'm only 1 vote out of 9. Everybody else gets a vote. And we do all things based upon majority wins. And that's how problem-based learning works. So what we would do is we would have specialists for each case. And instead of coming up with a plan to identify who the specialists are, some people pick dice, some people pick numbers, some people pick all different things, different ways to pick who the specialists are. I'll just appoint some people today. You'll be the physician, the patient, the reader, the scribe, and the other 4 people in the group will be active participants in the group. Now, the way the process works is I will give the reader first page of the case, and he or she will read it to the group. And the scribe will be up at the whiteboard putting all this information up on the whiteboard. And it might be something like this. Patient presents to emergency room with lower right quadrant pain. Patient is a 37-year-old female. Patient has a blood pressure of such and such, respirations of such and such, and temperature of such and such. And after you get this very, very minute amount of information, now we start to work on the case. So what happens, the scribe up the board puts together a line from the top to the bottom, and what we do, we start putting in something called differential diagnoses. What do you think the possibilities are that this patient has based upon this little bit of information? Well, lower right quadrant pain, female, what do you think it could be? It could be appendicitis, ovarian cyst, ectopic pregnancy, it could be some kind of muscle problem, a renal problem, it could be a lot of different things. So everyone in the group will start throwing out some possibilities. So let's say at the end of the session, this part of the session, we have 15 things that the possibilities that it could be. These 15 things we call differential diagnosis. Okay? After everyone's done throwing out some names that the scribe writes on the board, then we continue with the case. In which case I give the patient page 2 of the case. And he or she will look at this information. Basically what this is a patient history for this particular case. And he or she will look at this thing because what's going to happen, you as the physician, you're going to start doing a history of the patient. You're going to ask all kind of questions. How long have you had this pain? Do you have any vaginal bleeding? Do you have any rectal bleeding? Does it hurt more in the morning than the night? Any kind of food bothers it? And so you're going to basically doing a patient history. And one thing you're going to find out that at the end of the first 2 years, you're going to be doing a lot of patient histories. So when you're ready to start rotations in the third year, in the hospitals, in the clinics, in the physician's offices, you're going to be damn good at doing patient histories. You have to realize about 85% of the time, a doctor diagnoses the patient from the patient history, not the physical exam. So you guys are going to be very good and well trained doing patient histories, simply because of one course. Now we have other courses you're going to work in patient histories as well, but this is just a problem-based learning course. So after you ask all the questions that you could think of, if the patient still has any more information or any more knowledge about the case that you have not gotten from her, then the rest of the group will continue asking questions until everything the patient knows, everyone in the group knows. Then what you do is you're like a doc. You have more information, so what do? You go back to the differential diagnosis list. Okay? So now you can cross off a couple of these things. So if initially we started with 15, maybe you can cross off some of these things and maybe you're down to 10 or 11. Exact same thing that doc does, and you're going to be learning this the very first day of med school. Now chances are pretty good you're going to be way off target. That's good. Because if you're going to make any errors, make errors on the paper patients, not the real patients. This is good. The further away you are from what the actual case comes out to be, the better off it is. Simply because we can pull you back and start thinking through a more proper lens to diagnose the patient. Then what happens when everything that the patient knows, everyone else knows, and we go through the differential diagnoses list, then you'll say to me, Dr. Ron, what we'd like to do, we'd like to run some tests on this particular patient. That's the next step for a physician, run some tests. What kind of tests would you like to run? And the group decides, oh, what they want to do, they want to run an MRI of the lower right quadrant. And I ask, how many people have ever gone to a doc and that's the first test they run is an MRI? Probably nobody. Because I guarantee if that was a doc that did that, I guarantee within 2 weeks he'd be thrown out of the HMO. It's not cost effective. So you're going to learn cost effective medicine for your tests. So then what you would say, again, first day of class, you really don't know a lot about these tests. You say, well, we'd like to order a blood test. Well, what kind of a blood test would you like to order? Well, a big blood test, something we get a lot of information. So, well, that particular test that you're probably talking about is a CBC, complete blood count. And so I'm the insurance company. Why do you want to order that test? Because I'm going to pay for it. Unless you give me a good reason why you need to order the test, I can't order the test. So you would say something like, what we want to do, we want to identify if there's a bacterial infection or no bacterial infection. That's a good reason. So then what I would do, I would give the reader the results of the CBC, the complete blood count. He would read it to the group, and the scribe would put this up on the board. So what do we do next? We have more information. We go back to the differential diagnosis list. Exact same thing the physician does. So now you're down to maybe only 5 or 6 possibilities. So what you do, then you want to run a couple more tests. Well, the way problem-based learning works at the school is you meet Monday, Wednesdays, and Fridays for 2 hours each day for this particular course. Let's say our time to meet is Monday at 8 o'clock until 10 o'clock, Wednesday 8 to 10, and Friday 8 to 10. Well, at 15 minutes before the end of the session, what we do is we stop. No matter where we're at in the case, we stop. And we go around the room. And everyone gets to say positive and or negative things as to how the session went. You might say something like you were not really that good of a physician because you only asked 3 questions during the history. You were not focused on it. But you did a good job as a patient. The reader, you did a good job. Scribe, we couldn't understand half the stuff you wrote on the board. You came in 20 minutes late. You were really a big help because you were helping to form this team. So everybody's going to get positive and or negative criticism. This is tremendous. You will not believe how much students mature from this part of this session. I can tell you you're a belligerent SOB till you're blue in the face and you're going to blow me off. If 7 of your classmates tell you that, you're really going to think it. The maturity level just shoots up at a really exponential amount. You grow fantastically quick simply because of this. Then what happens at 10 o'clock, we stop. Wherever we're at in the case, we stop. And so what we do is the stuff that's on the board, the data that's on the board, everyone writes all this stuff down. And you're going to go home and you're going to do some research. Let's say the CBC showed the elevated white counts. Well, what are the possibilities for elevated white counts in that part of the body? So you're going to start doing some research. So when you come back on Wednesday morning, what we do, we set up the board, the whiteboard, exactly how it was when we left. The only difference is now you have a lot more knowledge of this case. So when you come up, first thing you say is, what we found is elevated basophil, so it can't be ectopic pregnancy, or it can't be ovarian cyst, it can't be this. So cross those things off. Exact same thing a physician does. And so usually by the end of the second day, we as a group solve the case. You ask me for more tests, I give you some more results, and then we solve the case. So then what happens on Friday morning from 8 o'clock until usually 9 o'clock, now how are you going to treat the patient? Now you have to come up with a treatment plan. So between Wednesday at 10 o'clock and Friday at 8 o'clock, you're going to do a lot of research. How am I going to treat this particular patient? That's how problem-based learning works. Now, you might ask, well, is there any tests in this particular course? Oh, of course there are. And you say, well, how can you test this? Well, you're going to tell us what you need to be tested on. By that I mean, let's say the patient has an ovarian cyst. Okay. Well, you needed to know the anatomy of the repro system. You need to know the physiology of the repro system for the ovarian cyst. You need to know the pathology. Now, how are you going to treat the patient? Now you have to come up with reproductive pharmacology. So what happens, you really tie all these ologies together. Now, it's a lot different than a traditional medical school, where you have anatomy for 25 weeks, then 10 weeks of physiology and 10 weeks of biochemistry. In the second year, 10 weeks of pharmacology, pathology, immunology, and microbiology. There's no connecting of the dots between all these different ologies. In problem-based learning, there's a real sound connecting of the dots. So you might want to ask, well, this is kind of a unique form of learning. How do students in this particular school, using this curriculum, compare with students at other schools using a traditional learning? Well, 2 years ago, on the part 1 of the medical boards, we had a 97% pass rate. Last year, we had a 97% pass rate. This year, we have a 100% pass rate on the osteopathic medical board. But then you might ask, well, how does this compare with MD students? Well, last year we graduated 136 students. 52 of them took the USMLE, which is the medical boards. Out of the 52 that took them, we had 19 of them with a 99. That's the highest you get. And out of these 19 students, only 3 of them were in the top 20 students in the class. So it wasn't like the best and the brightest took the USMLE. So the students do very well using this form of learning. In addition to problem-based learning, you're going to have some other courses. You'll have an osteopathic medicine course. That's the course where you learn how to use your hands to diagnose and treat patients. You learn about the hiccup thing and these other treatments for taking care of patients. You'll also have a clinical exam course. Clinical exam course, it's also a first and second year course. The PBL, OMM, and clinical exam, you will have every semester for the first 2 years. The clinical exam first semester, you'll learn how to do patient histories. You're going to spend the whole semester learning how to do patient histories. You might think that's overkill, but it really is not. Because what happens, you're going to do patient histories on each other. You're also going to do patient histories on standardized patients. These are people from the community that we pay for you to come in and do patient histories on them. What we'll do is we'll put you in one of our standard patient suites, standardized patient suites, and in there, it's just like a physician's office with the table and the blood pressure cuff, and just